Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Roche.
This program is presented by Medscape Education Global.
Hello, I'm Timothy Lai, a retinal specialist based in Hong Kong. Welcome to this activity titled Neovascular AMD Optimizing Disease Control for Your Patients. I'm really delighted to be joined today with my colleagues, Roberto, a retinal specialist based in Valencia, Spain, and Viril, a retinal specialist based in Chicago. As our title suggests, what we're talking about today is how to optimize disease control for your patients with neovascular AMD. With the longer durability agents becoming available to us, there was a lot of excitement that they could be part of the solution for the chronic undertreatment for these patients that happens in very often. So we are going to talk about whether this reality lives up to that hope and how best to use the available therapies to control our patients' disease activity in these patients with neovascular AMD. So let's talk about durability first. The clinical trials of faricimab and aflibercept 8 mg, they were designed as non-inferiority trials to see if they could get the same outcomes as we do with aflibercept 2 mg every 8 weekly, but with fewer injections. And in the trials, a large proportion of patients could be treated every 12 or 16 weekly. So Viril, are you seeing these results in your real clinical practice?
Yeah, that's a great question. I think we have the benefit of having these treatments now for quite some time, a few years even. And so we're seeing in the real world some of this data matching what we saw in the clinical trials. In other words, a good number of patients getting to 12 weeks, 16 weeks durability, which really is a meaningful difference for those patients.
And so, Roberto, there are many registries out there and also real-world studies using both faricimab and also aflibercept 8 mg. So what can you tell us about these clinical trials in the real world?
Well, as you perfectly said, durability is key to cover our own deficiencies in managing the disease for a long time. So we have a variety of real-life results when managing these new drugs with longer durability. And in summary, what we can tell is that patients are being injected mostly half of the times that they were used to be receiving injections. So both far retina, iris vestrum, even the trachea, right, Viral, are showing a tremendous benefit for patients, caregivers, and physicians by decreasing significantly the number of injections without damaging the final visual outcome.
And so how about review in the States? Of course, there's the trachea studies. Can you tell us about it?
Yeah, I think the thing that we are very good at as specialists is collecting data from the moment a new treatment becomes available. And so trachea, we've been collecting data for faricimab for over 3 years now. And so a lot of those patients that were switched early on, we have now 3 years of follow-up. We see a lot of those patients have had multiple 8, 9 injections, for example. And some of the latest data that we've seen from that type of a study is that patients are showing good durability, good safety. Again, things that you want to see in the real world with newer treatments.
That's great. So let's talk about drying. So that's another very important issue. So how these therapeutics, are they drying as well in the real world compared with the clinical trials?
Yeah, so the clinical trials are not necessarily primarily designed to look at these head-to-head, especially in terms of drying. But there are parts of these clinical trials, especially those first few weeks where you're doing a loading dose, so first 16 weeks in a study like Tenaya or Lucerne, for example. And when you look at those slices of data, you do see that patients that receive faricimab do tend to dry faster and more effectively than patients that were on the control group, in that case, aflibercept 2 milligrams. So we do have some data. And then I think you see some real world data as well in patients that are switching, for example, that those patients are also starting to dry out a little bit too. So I think there's a lot more data coming out that's showing that patients do dry pretty well. But you're right, head-to-head data is always hard to find.
Yep. How about the extension studies? So there are now some phase 3 studies which have been extended further to like 3 and 4 years results. So can you tell us more about that?
Yeah, so one of the more recent data sets that's come out is the Avenel X data set. So this was patients that were in Tenaya and Lucerne. So they received for 2 years either faricimab in a treat and extend fashion or aflibercept every 8 weeks. Those patients rolled into an extension for another 2 years where they were able to receive faricimab. And so now we have data in a very closely monitored clinical trial setting that for patients that have had 4 years potentially of faricimab treatment. And so what we see in those types of studies, we see efficacy, right? We see patients that have sustained vision improvements in years 3 and 4, where we know sometimes in real world data sets, we don't see that sustained vision improvement. We see anatomic improvement that's sustained over years 3 and 4. And all those things are done with fewer injections. I think Roberto mentioned, this is a really meaningful change for our patients if we can not trade off efficacy, but still give patients anatomic benefits with fewer injections over time. So in years 3 and 4 in the Avenel study, for example, patients received 7 injections, right? That's over the course of 2 years, but still we did not sacrifice vision or anatomy. And then the other thing I think is important in these studies are in Avenel X, patients were switched at the end of the parent study from aflibercept to faricimab. So everyone was receiving faricimab in those last 2 years. And there was a group of patients that was receiving aflibercept that still had residual fluid. So about 152 patients at the end of 2 years of consistent aflibercept treatment still had intraretinal fluid or subretinal fluid. And when those patients were switched, at the end of the extension, we saw that 44% of those were fluid-free by the end. And so perhaps, these new mechanisms of action, dual mechanism of action with faricimab, things like that, higher dose in the 8 milligrams, those things are going to benefit our patients.
So thank you very much for talking about the Avenel X study. So as you know, Roberto, there's also another extension study for the patients in the Pulsar study. So can you tell us about that?
Yeah, absolutely. We are lucky enough to have another drug working in a very similar fashion to what Viral was just explaining. We have the aflibercept 8 milligrams, which showed during the extension, immediately following the Pulsar trial, that the number of injections with all patients managed with aflibercept 8 milligrams decreased with maintenance in vision and with maintenance of visual gains and structural changes. So it's not like in previous years when we ourselves were decreasing the number of injections because we couldn't manage the situation and the number of patients flooding our clinics. It looks like these drugs work and the durability is significantly better than the previous drugs.
Very good. So let's talk about switching now. So what are the characteristics of patients that you think will benefit from switching to these longer durability agents? So Faril, can you talk about that?
Yeah, I think anytime we have a new treatment, I think the first group of patients that gets the new treatment are the patients that we consider are poor responders. They've been getting whatever the standard of care is at that time, but just not achieving the benefits that we think are in their ideal scenario. So for me personally, the patients I switch are patients that still have residual fluid, intraretinal fluid, subretinal fluid in those patients that I think can do better. Those are the ones that are the ideal switch candidates for me. And we often will switch to one of these newer agents to see if we can dry better in those patients.
So Roberto, is there any other scenario that you will consider switching these patients?
Yeah, well, I completely agree with Viral. The truth is that even you have a dry macula in a patient that is coming very often to the clinic, they all benefit from a significant extension. So for everybody, if you have patients under control with injections given every 4-6 weeks, that's not very good for patients and for caregivers. So it makes a lot of sense, given that we have learned so much at this point about the efficacy and safety of these new drugs with superior durability. It makes a lot of sense to switch them too, although they are anatomically under control, because you decrease the number of visits, number of injections. So again, that's a win-win for everybody.
Yeah. So if these patients, you mentioned about 4 to 6 weeks, how about patients, for example, dry on 12 weekly intervals? So would you switch these patients as well?
Those are a little more difficult, I think, because those patients, when they're coming in every 3 months for a treatment, a lot of times they're happy. And this is one of those where I may not switch them necessarily, because they're doing well. But absolutely, I agree with Roberto. Those patients that are at 4 to 6 weeks, much easier conversation. Why are we switching you? Let's try to get a couple more weeks out of it. And I think it has a meaningful impact on their quality of life, caregivers' quality of life, everybody.
Hmm, that's great. Yeah. So, is there any evidence to support this selection of switching? So, maybe review, can you explain about these persistent fluid patients, for example?
Yeah, a lot of our switch data comes from real world data. And so, we were talking about Truckee, and in that Truckee group of patients, the vast majority of patients that were in that subset or that cohort early on were switch patients. And most of those were switching from either aflibercept 2 milligram or bevacizumab, for example. And what we saw is that upon those switches, we saw resolution of fluid in many of those patients, and sustained durability in those patients as well.
And how about from other study, for example, Virtual? Do you have any suggestions?
Yeah, it's in a similar way. Aflibercept 8 milligram proved through the pulsar extension study that the anatomical benefit also increases after switching patients from 2 milligrams to 8 milligrams aflibercept, with a decrease in the number of patients showing macular leakage and the area of leakage. So there's an anatomical benefit added to the durability benefit when switching patients. So again, what we are learning is that both faricimab and aflibercept 8 milligrams improve a lot our life, our patients' lives, and the quality of eye care that we can provide them.
Yeah, it's good to know that there's strong evidence supporting these patients who switch to these newer durability agents. So, because we now have clinical trials with the year 3 and year 4 data, for example. So, how do you see what have you learned from these trials about the safety?
Yeah, the nice thing about these trials now, these phase 3 studies that have gone into extension, is that we have patients that have been on these treatments for a long time, 4 years, for many of these in the AVNLX study, for example. And what we've seen is that there are really low adverse event rates. I mean, I think we are much more aware, hypercritical about safety these days. And in a clinical trial setting, a little bit different than real world setting, is in a clinical trial setting, we're looking at these patients very closely. Every time they come in, we're looking at them under a microscope, literally. And so if there's any IOI or any evidence of a vasculitis, we're gonna pick it up very quickly. And the good news is, in an extension like AVNLX, we didn't see any retinal vasculitis, no occlusive disease, which is meaningful, and I think matches up with what we're seeing in the real world as well.
So, Roberto, how about in the PULSAR extension study?
What we have learned from pulsar study is that aflibercept 8 milligrams has an absolutely similar uh, safety profile compared to the aflibercept 2 milligrams. There's no increase in adverse ocular events compared to the previous drug. And as Biral was saying, we're extremely concerned about severe intraocular reactions to new drugs. And this is not happening. This is not happening for aflibercept. This is not happening for faricimab. And the good thing is that at this point, thanks to real-world data, it's not only about the clinical trial. After a significant number of treatments in the real world, we haven't noticed a safety signal at all.
So, in real world practice, are you also seeing these good safety profile for real?
Yeah, I think it's important to look at the real world data, because in real world data, we have all comers, right? In clinical trials, it's a very kind of select group of patients that we have, and we kind of weed out some of the more risky patients. But in the real world, everybody's included in these data sets. And so Yes, we're seeing good safety profile. We're seeing really no adverse events that are outside of what we would expect. Of course, we'll get an occasional endophthalmitis and things like that, which is going to happen with any intravitreal injection, but no major cases of vasculitis or occlusive disease, which is really what our primary concern is these days.
Okay, now let's talk about switching. I think, Roberto, you actually have a case to share with us to put these aspects of the data into real world practice. So, can you share with us with a case, please?
I would love to, Tim. Thank you. Uh, you see, this beautiful case is going to illustrate a lot of things that we have been discussing. Look at this image. We can see a large PED, predominantly serous, with subretinal hyperreflective material, even with a basilar laminar layer detachment, subretinal fluid, a lot of activity, exudative activity at the beginning. And this patient was managed with aflibercept 2 milligrams. So we achieved a visual improvement, but with suboptimal response in terms of anatomy. And there is organization of that subretinal hyperreflective material. We see persistence of subretinal fluid, and although the PED decreases in height, there's no very outstanding resolution of it. So at that point, we had available faricimab, only faricimab at that point in Spain. So we decided to propose change to that treatment to the patient, and she gladly accepted because she was not doing very well. And this is the very initial response to faricimab. So we achieved complete resolution of exudative manifestations, the PED decreased, there was some persistence of subretinal hyperreflective material, but look what happens when we keep treating the patients with faricimab. It fades away too, and the outer retina reappears, leading to a significant visual improvement. So faricimab rescued vision and anatomy in this particular AMD case. That was my personal approach. I don't know, how would you manage situations like this in your routine clinical practice?
Yeah, I mean, I think this is a great case, and I think we all have cases like this, right, where this patient came in, large PED, and I think with these newer agents, there's a potency to these agents that allows for these PEDs to resolve much more quickly and much more effectively. So I think the real question is really, do you learn from these cases and do you start these patients off with these newer treatments, right? Because there are certain kind of risk factors that do make me worry about a patient like this. And so the question is, should we start earlier in these cases or switch earlier at least?
Yeah, I think you mentioned about early switching. It's quite important because you really do not want to have the deterioration in these cases. If you have deterioration of VA, for example, in some cases in Asia, we see a lot of PCV cases. If you leave it untreated, these polypoidal lesions might bleed, and a massive bleed can cause irreversible visual loss.
That's right.
Yeah.
I couldn't agree more. I mean, if you have a superior agent in terms of efficacy later on in terms of durability, why should you keep that? You use it as soon as possible, no matter what the case is.
Yeah, because out there's some physicians saying, I pray we'll save these more durable and more effective agent a bit later as a second line or third line agent. But based on the clinical trial data and also the real world data, I think there's no good evidence to withhold these treatment, right?
That's right.
Yeah.
And you mentioned PED, definitely one of the diseases that we struggle at times when managing PEDs is PCB, right?
Yeah. So PCV is another very important issue, especially in Asia. So we see a lot of these patients with polypoidal choroidal vasculopathy. So fortunately, we have also very good data recently. So the Selwyn 1-year data was just reported in Euretina this year. And the results show that with the use of faricimab, the patient had very good visual acuity gain. They gained 8.9 letters at 1 year. And also there was very good reduction in terms of anatomical thickness. And the most remarkable result is the use of faricimab in this patient is looking at the ICGA polypoidal lesion closure rate. So at 1 year, the closure rate was actually 60%, which is very remarkable with using a faricimab monotherapy. And in terms of inactivation of the polypoidal lesion, you could actually get up to about 80%, which is also very remarkable. And in terms of durability, you also get very good result because Selwyn, the design is very special because in the second year, you're actually allowed to have a Q20 weekly interval of injection. So in these patients, at 1 year, over 50% of patients were able to be assigned to Q20 weekly dosing. And also, of course, we now also have some data on the subgroup analysis from pulse of these PCV patients. So Roberto, can you share with us what the findings are?
Yeah, the very interesting thing about that is that the behavior of patients with PCB in the Pulsar trial mimics the visual and anatomical behavior when compared to non-PCB patients. So you obtain a significant visual benefit with a wonderful anatomical response. And again, the presence of polypoidal lesions after treatment with aflibercept 8 milligram decrease is remarkable in terms of the lesion itself and the activity of it, as you clearly mentioned about faricimab.
That's great. Now, Viviu, I think you also have a case to share with us. Can you tell us about it?
Yeah, I think I like cases a lot. I think, the data that we talk about is important, but it's in aggregate. So it's hard to connect it with patients that we see day to day in our office. And I think these types of cases help us connect with how we practice in our own clinical practices. And so I have an example of a 83-year-old female I've been treating for a long time in my office. And I had been treating her for a long time with the aflibercept 2 milligrams, about every 6 weeks. And the difficulty with this patient, now this is where the real world is important because all these other variables come into play. The difficulty here with this patient is that she had a hard time coming into the office. We talk a lot about caregivers and all the other things that have to take place for these patients to get to our office to get these treatments. And she was having more and more difficulty over time. So for her, this is back in 2020, we decided, let's try this new treatment. And at that time, brolucizumab was the newest treatment we had available, in hopes that we could dry her out better, because even at 6-week interval of aflibercept, she still had subretinal fluid, in hopes that we could dry her out better and also extend her interval out to decrease some of the treatment burden on her. We switch her to brolucizumab, and she does well. She does kind of as I would predict, which is that fluid that was residual did dry out. And after a few injections, we were able to extend her out to up to 10 weeks. And so she did very well. She was happy. She was coming in less often. She was doing better clinically. But we all know that at some point in time, brolucizumab became a concern for many of us as clinicians because of some of the adverse events that we were seeing. So I had a conversation with her and I said, look, I don't feel comfortable at this point keeping you on this treatment. Why don't we switch you to another treatment? And so we switched back to aflibercept. Now, I kept her interval the same. I switched her back to aflibercept in hopes that she would remain dry after 2 years of suppressing this fluid. But lo and behold, at 10 weeks, she has fluid again at 10 weeks. And so now we have to have this conversation, which is a difficult conversation for a patient that's done very well over a few years. And so the question I would pose to both of you, maybe Roberto, we start with you, which is, you have this patient, and I'm sure you've had many of these types of patients in your office. What do you do at this point?
Well, I think we could have that conversation again with the patient. And one of the things that are super useful in this conversation at our decision is that pointing out that our decision is reversible, meaning that if the patient is not comfortable or if it's not frequent, but in case that we are not able to extend the visits as we expect, we can come back to the previous treatment if the patient wishes. So they are extremely familiar with injections. So you are just changing the drug that they are they will be receiving inside the eye. So surprisingly to me, they understand perfectly well this drug discussion. And most patients really love the new thing.
Yeah.
So that makes easier to change to faricimab or aflibercept 8 milligrams in our hands.
So in this case, you would switch this patient to one of the newer agents.
I
Would
think
you
so.
would you change the duration? Right now, I have her at 10 weeks.
Not really.
Yeah.
So I'm not sure how you manage the situation, but in cases like this with minor, very subtle subretinal fluid, I think I might repeat the same interval as the previous drug was being beneficial.
Yeah, I agree. I don't like changing too many variables at once. So if we're changing the medication, let's leave the other variables the same.
And also, if you are injecting every 10 weeks, if you go for 4 weeks in the next
Right.
injection, the patient may not understand anything
That's right.
about what you're doing, right?
Yeah. Tim, would you do anything different?
Well, I think what Roberto mentioned was very important. So you just basically try to talk to your patients to get them understand the aim of the changing the switching. So now we have these new agents, so we can have two options: either switching to 8 milligrams aflibercept. In your case, the patient was already on 2 milligrams aflibercept, so it might be easier to communicate. Just is stepping up the dose, just like when you're taking, for example, your anti-cholesterol drug or taking antihypertensive, you're increasing the dose. So some patients might like that idea. Or the other option is to change to a new drug, which is Versumab. And I think, of course, some patients will respond better to one or the other, or both drug will have the similar effects on the patient. So you never know. So that's why you have to explain the patient to tell them what's your aim of the treatment. So hopefully we can try the macula better, as well as increase the durability and increase the treatment intervals for these patients.
Yeah, agreed.
Okay, so as you've heard from the two cases, I think it's very illustrative that these more durable agents, they actually can dry the macula better and also increase the treatment interval for these patients. So I think these are all very practical points to optimize the disease control of your patients. So in treatment-naive cases, for example, I think you really should start with these stronger, drying, and more durable agents. In switching patients, also consider switching them early, because you don't really want to wait for the visual deterioration, which might be irreversible. So you want to switch them early so that you can get the full benefit earlier. And in terms of using these agents are actually very useful for the treat and extend regimen, because of the longer durability. So you can increase the treatment interval for these patients substantially and reduce the burden of care. So this is now the standard of care for many of the patients with neovascular AMD. And also with these newer agents, as you have seen from the data from various trials, in terms of drying effect, and also in terms of, for example, in PCV, you also can get more complete regression of the polypoidal lesions in the clinical trial. So these very difficult cases, for example, PED and PCV cases, I think you really should use these newer agents.
Yeah.
So thank you very much, Viviu and Roberto, for your time and for sharing your great cases. And it's been a wonderful discussion. Thank you so much.
Thank you.
Thank you, Tim.
And thank you for participating in this activity. So please continue on to answer the questions that follow and complete the evaluation. Thank you very much.
This program was presented by Medscape Education Global.